Let's begin our discussion on meningitis. Meningitis is inflammation of the meninges, or the outer layers covering the brain and spinal cord. Do you remember what the three layers of the meninges are? From the inside to the outside, the spinal cord here, it is the pia mater, the arachnoid mater, and the dura mater. Remember, the meningeal layers pad the spinal cord. And what are some classic presenting symptoms of someone with meningitis? A patient with meningitis would present with fever, neutral rigidity, and photophobia, just to name a few. A number of different microbiota can cause meningitis. A great way to remember the different causes is to break it down by age group. First, let us look at the age groups and remember the rule of sixes: 0 to 6 months, 6 months to 6 years, 6 to 60 years, and 60 years and older. This is a great way that we can use to categorize the bacteria using ages that are pretty easy to remember. In newborn, the causes of meningitis are similar to the causes of pneumonia. We could see group B strep, E. coli, and listeria as causes of meningitis. Moving on to older age groups, we will see that strep pneumoniae is the most common cause of meningitis in patients older than 6 months old. This is a favorite question on the boards because, largely due to its name, people usually associate strep pneumoniae with pneumonia rather than meningitis. So in addition to pneumonia and meningitis, what other two key infections is strep pneumo responsible for? Cause meningitis, it would cause otitis media, sinusitis, and pneumonia. So we can remember the mnemonic MOPS. In addition to strep pneumo, children between 6 months and 6 years can get meningitis from Neisseria meningitidis, Haemophilus influenza type B, and enteroviruses such as the Coxsackie virus. Can you remember nowadays why we don't often see infection or meningitis from Haemophilus influenza type B? Well, this is because of the new conjugate vaccine that we just started using in the last 10 to 15 years. The boards will like to test you on this by giving a case of a patient from another country or someone who did not receive their pediatric vaccinations. If they give you that information in the stem of the question, take note of it and consider they might be going after the fact that Haemophilus has an important vaccine associated with it. I have written HIB here on the slide to remind you that this is the abbreviation of the vaccine. Do you remember some other life-threatening diseases that can be caused by Haemophilus influenza in unvaccinated children? The most serious life-threatening disease is epiglottitis. It can also cause otitis media as well as pneumonia. Do you remember how you would treat Haemophilus influenza meningitis? The drug of choice for this infection is a third-generation cephalosporin, ceftriaxone. Is there anything you could give to close contacts for prophylaxis? Sounds like a yes question, and you can give them rifampin. In older children, through adults from 6 years to 60 years, meningitis can be caused by strep pneumoniae, Neisseria meningitidis, enterovirus, as well as herpes simplex virus. It is important to note that the Neisseria meningitidis is the most common cause of meningitis in teenagers, specifically those in college or military dormitories, or people living in tight spaces. Lastly, in patients over the age of 60, we will commonly see infections from strep pneumoniae, as well as gram-negative rods and listeria. I know these lists can get long and it sometimes is difficult to appreciate what is important, but the most important point here is that neonates are affected by GBS, E. coli, and listeria, and that strep pneumo and Neisseria meningitidis are the most common causes of meningitis in children and adults, and strep pneumo is the most common cause in elderly. In HIV patients, it's important to remember that Cryptococcus neoformans is a very important cause of meningitis. But more importantly, On your boards, the examiners are going to want to test your ability to analyze cerebrospinal fluid findings in different kinds of meningitis, which we go over at a different point in this lecture. So now let's talk about encephalitis. How does encephalitis differ from meningitis? To help answer this question, here's a simple diagram of the spinal cord and the brain. The brain and spinal cord consist of the central nervous system, and they are surrounded by a layer of meninges, specifically the pia, arachnoid, and dura mater. Meningitis is an infection of one of the layers of the meninges, the pia, arachnoid, or dura mater. Encephalitis is infection of the brain parenchyma, or the actual brain tissue. Important to remember that encephalon is a fancy term for brain, so encephalitis means infection of the brain. This is a subtle but actually a very important difference. So what are some causes of encephalitis? Encephalitis is most commonly caused by viruses, including the arboviruses, as we talked about before, such as the West Nile virus, the equine viruses, including the Eastern and Western equine and St. Louis encephalitis virus, as well as the rabies virus and herpes simplex 1 virus. On the boards, the most commonly tested cause of encephalitis is actually HSV1. This virus actually causes a specific type of encephalitis. Do you remember which type? It causes encephalitis of the temporal lobe. What diagnostic test would you use to detect HSV1? The test of choice is to do a PCR of the spinal fluid to test for viral DNA. And one last question. Do you remember what bug can cause a life-threatening meningoencephalitis that has a very poor prognosis and is associated with diving into freshwater pools? That would be Naegleria fowleri. So now let's spend some time discussing how we work up meningitis. When a patient comes into the ER with fever, neck stiffness, and a headache, we must consider meningitis. When this is suspected, a lumbar puncture is performed, also known as a spinal tap. As you can see in this image, the needle is inserted between the lumbar vertebra, usually between lumbar 3 and lumbar 4. It is pushed into the subarachnoid space, which is the space between the arachnoid and pia mater. So thinking back to anatomy, can anyone tell me the two structurally important layers the needle must pass through in order to get into this space? So classically, 2 pops are produced when the needle goes through these 2 layers. The layers are the ligamentum flavum and the dura mater. Very good. As soon as the needle reaches the subarachnoid space, the pressure of the CSF is measured by a column manometer. An increase in CSF pressure is a sign of bacterial or fungal meningitis. Then, with the needle firmly in place, we take samples of the cerebrospinal fluid and send them to microbiology for measurements. There are 3 key things measured by the laboratory when you send them a patient's CSF: the presence and type of cell in the CSF, the protein level, and the level of sugar. Now, it's important to remember there should not be any cells in a normal CSF. In normal CSF, the protein in the CSF should be less than in the blood, and in terms of blood glucose, the blood glucose of the CSF is usually about 2/3 of the glucose concentration in the bloodstream. So if there's for example, if there's 100 milligrams per deciliter of glucose in the blood, there should be about 66 milligrams per deciliter in the CSF, roughly. So now let's compare and contrast how these different values differ in bacterial, viral, and fungal meningitis. This is very high yield for step 1, and I can almost guarantee you'll see a question like this on your exam day. First, let's consider the opening pressure. The pressure increases in fungal and bacterial meningitis and stays pretty normal or slightly elevated in viral meningitis. The way I think about this is that since bacteria and fungi are bigger organisms than viruses, they take up more space in the CSF, causing an increase in pressure. The cell type found in the spinal fluid is probably the highest yield information. This is the first thing I typically look at when I'm analyzing a CSF fluid because it splits up bacterial meningitis from fungal and viral meningitis. In bacterial meningitis, we will see an increase in neutrophils, or polymorphonuclear cells, PMNs. And why is this? Can you tell me? Well, if we remember back to immunology, neutrophils have toll-like receptors, TLRs, that recognize bacteria and are actually the most responsible for killing them. So neutrophils respond to bacterial infections and therefore will be found in the CSF. In contrast, in fungal and viral meningitis, we're most likely going to see lymphocytes in the CSF because these are the main cell type involved in killing these types of organisms. So just to review, the first thing you should look at when given a CSF study is the cell type. If it is filled with neutrophils or PMNs, it is bacterial meningitis without question. If it has lymphocytes, then it can either be viral or fungal, and that is when we rely on the protein in the CSF glucose levels to help with differentiating. So to compare the protein levels between fungal and viral, we can see that protein in viral meningitis usually stays normal or is slightly increased, while in fungal meningitis or TB meningitis, for that matter, we're going to see an increase in protein along with bacterial meningitis. So if it is lymphocytes and there is an increase in protein, then we're most likely looking at a fungal meningitis, while if it's a normal or an increased protein level in the CSF with lymphocytes, probably looking at a viral meningitis. The same pattern holds true for sugar or glucose levels. The way I think about this is to think about bacteria and fungi as kind of invaders, big guys coming into the CSF and eating up all the sugars, while the viruses are just snooping around, minding their own business, not really touching the sugar. The viruses really just sneak into the meningeal cells and hang out. They replicate themselves, kind of minding their own business. They do not consume glucose like the hungry bacteria or fungi. The bacteria and fungi are the real cells that are hanging out in the CSF, eating sugar, making lots of protein, while the viruses are low-key, hiding in other cells, and not having a major impact on the extracellular fluid around them. Here is a simple algorithm I want you to cram into your brain for the CSF analysis. The first step is analyze cell type. If it's PMNs or neutrophils, then we're already knowing it's bacterial meningitis. If it's lymphocytes, the next thing we want to do is analyze glucose levels, and if they're normal, then we're thinking about viral meningitis, and if they're decreased, we're thinking about fungal meningitis. Now time for a flash quiz. What is the most common cause of meningitis in individuals older than 6 months of age? I'm really trying to drill this in here. The answer is strep pneumoniae.